Perfect. Thank you. Thank you all for joining us today. We're happy that you could have some time to attend. We really appreciate it. My name is Jennifer Miranda. I've met some of you. I am a pharmacy case management supervisor here at Mountain Pacific. And I also come from a 15-year clinical background. I was a clinical pharmacist practitioner and I'm board certified in ambulatory care. So today's presentation is around stigmas surrounding opioid use disorder. And just so you know, we are going to save questions till the end, but you can put them in the chat box. And when I'm done speaking, Amber will let me know what those questions are. So thank you. Next slide, please. So for disclosures, I mentioned where I'm employed. I also have no relevant financial relationships with any ineligible companies to disclose. And this project is funded in whole or in part under a contract with the Montana Department of Public Health and Human Services. And the statements herein do not necessarily reflect the opinion of DPHHS. Next slide. So what is stigma? The Oxford Dictionary defines stigma as a mark of disgrace associated with a particular circumstance, quality, or person. Some synonyms for stigma include shame, disgrace, dishonor, disapproval, a blemish, a brand, or a mark. There are also two different kinds of stigma. There's self-stigma and public stigma. Self-stigma is the belief that people hold of themselves, and public stigma is the belief that is held towards a specific group or person. Next slide, please. An example of stigma would be a 13-year-old boy named Ryan White, who was diagnosed with AIDS in December of 1984. He was one of the first children in the United States to be diagnosed with acquired immunodeficiency syndrome, or AIDS. Prior to his diagnosis, AIDS was thought to only affect homosexual men. He had been ill, and the source of the AIDS was found to be from a blood transfusion related to the hemophilia that he was born with. He had to battle through the court system in order to attend public school, and that took several years within the court system. When he returned to school, 27 children were pulled out of the school by their parents and transferred to a new school. Next slide. So some other stigma and perceptions that surrounded AIDS were in 1985, 80% of Americans said it was probably true that most people with AIDS were homosexual men. 44% of Americans also avoided places where homosexuals may be present, such as a bathhouse, to avoid contracting AIDS. In 1987, 2 years later, 51% of Americans agreed it was people's own fault if they had AIDS, and 44% of Americans believed AIDS might be God's punishment for immoral sexual behavior. During Ryan White's 5-year battle with AIDS, he was able to change the face and the stigmas associated with AIDS worldwide. And in April 1990, he passed away. Next slide, please. However, knowledge is power, and hopefully we can learn from our mistakes about stigmas associated with diseases. We learned that AIDS could not be transferred to someone just by being in the same room. In 1989, Princess Diana visited the pediatric AIDS unit in the Harlem Hospital in New York City. She hugged young children that were afflicted with AIDS and taught us that we could not get AIDS just by touching someone who had AIDS. Magic Johnson also was a player in the NBA who tested positive for HIV in 1991. He was heterosexual. He retired from the game he loved and became an advocate to reduce stigma related to HIV and AIDS, and it worked. These were people that helped to eliminate stigma around AIDS, and we can help to do the same regarding stigmas surrounding opioid use disorder. Because of the work that's been done with HIV, infections that are diagnosed have decreased yearly from 2015 to 2019, which was the most recent data. However, the goal by the CDC is to end the HIV epidemic in the year 2030. So again, we can do the same with opioid use disorder. Next slide, please. Factors that led to opioid use disorder were things such as believing that we could treat pain as the fifth vital sign and that we should. In 1995, Dr. James Campbell addressed the American Pain Society and urged providers to do just that. We were also taught that there was no ceiling dose to the opioid. Providers and pharmacists were educated there were no dosage limits as long as it was for chronic pain. Pseudo-addiction is a term that drug manufacturers coined to describe symptoms of addiction that they said were not truly indicative of an actual addiction, and instead were indicative of the patient needing a higher opioid dose. We later found out that this was not true. Next slide, please. Factors that led to the stigma surrounding opioid use disorder were things such as the Just Say No campaign, which was part of the Ronald Reagan era, where we were told that we could just say no, and it was really that simple. This was to discourage children from using illegal drugs in the 1980s and early 90s, but we continued that mentality even until now, where we sometimes believe that it really is just that simple. We also started criminalizing selling of opioids on the street and thought that we could put you in jail so that we could criminalize your activity, and that would force you to not want to use an opioid. We did not treat it like it was a disease, and we believed if we imprison people, we could stop opioid use disorder. And we also believed addiction was mind over matter, and if someone relapses, then they just must not have wanted to be sober bad enough. Next slide, please. Here are some statistics related to opioid use disorder. In the United States, 2.7 million people suffer from OUD. There were almost 81,000 overdose-related deaths from opioids alone in 2021. And Alaska was the state that saw the largest increase in overdose deaths, with an increase of 75.3% in 2021. As you can see here, there's also other drugs listed here, which include methamphetamine, psychostimulants, cocaine, and natural or semi-synthetic prescription medications. These deaths are believed to be related to the fact that fentanyl is in a lot of these medications now that are purchased on the street, or illicit substances. Next slide, please. Stigma is a barrier to treatment. It is known that only 1 in 4 people with OUD will seek treatment. Stigma surrounding OUD impedes access to treatment and affects care delivery. It also contributes to the disorder on an individual level. And OUD stigma is different than stigmas that are surrounding other conditions due to the co-occurring issues that are often in the lives of someone with OUD. This is because drug use turns on the reward pathways within the brain, which can affect our mood and also our stress level. It's often also a way to cope with a life that's been filled with trauma or mental health disorder. Due to the chemical imbalance or withdrawal symptoms seen with OUD, some people may act out and lie or steal or act in an aggressive manner, which people can then in turn judge further. Next slide, please. There's also resistance in believing the addiction is an actual disease. Stigma, Dr. Nora Volkow, the director of the National Institute on Drug Abuse, had a great quote where she said, stigma plays an even larger role in this crisis. When internalized, stigma and the painful isolation it produces encourage further drug taking, which directly exacerbates the disease. We also know that shame leads to mistrust of providers and avoidance of healthcare, and not just for OUD, but for all disease states. Next slide, please. Kristen Johnson, you may remember her. She was an Emmy Award-winning actress who starred in the 90s television sitcom Third Rock from the Sun. She explains stigma best. In the movie Anonymous People, she said the shame and secrecy is just as deadly as the disease itself. And I think it's important for us to remember that as professionals. Next slide, please. Overdose death disparities is also something to think about when we talk about stigma and OUD. So disfavoring a specific population group increases the risk of leading to stigma. The deaths are disproportionately higher for Native Americans, Alaska Natives, and African Americans. As you can see on the right side of that slide, the CDC published in their Morbidity and Mortality Weekly Report in July 2019, the increase in overdose deaths that were seen in a one-year period from 2019 to 2020. There was a 22% increase in death in white Americans as compared to a 39% increase in Native American and Alaska Natives, and a 44% increase in African Americans. Other high risk factors for an overdose include being a male, having a low income, or recent release from incarceration. The release from incarceration is interesting because that is multifactorial. They believe that part of the reason that those overdose or deaths are higher is because some of those people have been incarcerated and they're actually not aware of the seriousness and the commonality of fentanyl in street substances. And so they're just oblivious that that can actually happen. And then the second thing is a lot of people that are getting out from being incarcerated are not given Suboxone, and so they have cravings, and as soon as they get out, they act on those cravings. Next slide, please. Age disparities are also relevant. Data is conflicting and ever changing, but concerns that are noted in the older age group, being age 65 years and older, include the number of chronic conditions that can increase the risk of an overdose. These chronic conditions include chronic kidney disease, a decline in liver function, which can both affect the metabolism of the medication, and also COPD, which can affect breathing and respiratory depression. There's also, did I say next slide? Sorry, I think I did. Okay. The next thing is polypharmacy. As we age, we tend to need multiple medications, and that can also increase the risk for a drug interaction and also increase the risk for respiratory depression. And then the need for prescribed opioids can increase also as we age, as the elderly are more likely to experience a hip fracture or a cancer diagnosis, both of which often require an opioid for pain management. And a decline in cognitive function, because as we age, dementia and Alzheimer's diagnoses are also more common and can increase the risk of an accidental fatal overdose. Concerns in the younger age group, age 12 to 25 years old, include that that's the age group that's most susceptible to engage in high-risk behaviors, more likely to believe that they are invincible, and to trust their friends completely. So if a friend says, oh no, I know that this pill is for anxiety and I know it's not tainted with anything, that person might actually believe that and probably does, but the person they're giving it to will also trust them. Next slide, please. Disparities in receiving treatment. The state unintentional drug overdose reporting system, or SUDOR's, data from 2019 to 2020 looked at 25 states and the District of Columbia in publishing this report that was in Morbidity and Mortality through the CDC. So deaths in Black males were 7 times higher in those states combined versus those in non-Hispanic white males. And 16.4% of non-Hispanics had received treatment, compared to only 8.3% of African Americans and 10.7% of Native Americans. Next slide, please. Potential causes of disparities include secondary effects of income inequality. So talking unstable housing, unequal insurance coverage, possibly unreliable transportation. We have healthcare disparities, meaning that we can have decreased access to healthcare, which also affects access to getting treatment for OUD or any other healthcare problem. Insufficient resources. The OUD treatment facility may be a long distance away, and the patient may not have enough gas money to travel to the appointment. There's also lack of support networks. So the cost of childcare might be unaffordable, or they might not have relatives that can help out or are sober enough to help out. And that can lead to an unavailability of childcare. Intergenerational trauma, alcoholism, drug addiction, mental health is also seen in many people with OUD and can be a potential cause of disparity. And then we have discrimination, which I touched on above. Next slide, please. How can we decrease stigma? So we should treat people with OUD the same way we would treat those with diabetes. An addict is a person with OUD. We do not call a person with cancer a cancer. Words matter. Avoid stigmatizing language. So avoid the word such as abuse, a junkie, sneaky, irresponsible, or when interpreting your analysis, don't use the words dirty and clean. Use the words, it was positive for methamphetamine, it was negative for methamphetamine, that sort of thing. The negative connotations can affect morale and hope, which are critical to these patients. Also use harm reduction strategies. So it's important to offer naloxone and also to improve access to sterile syringes. Those are just a couple of the ways we can reduce harm. Recognize and remove unconscious bias. So be aware of both the anatomical and physiological mechanisms of addiction. We were trained to, or at least I was, to think that rehab alone could keep people away from opioids. And if it did not, then possibly they were just weak. We need to work on trying to change that mentality from within. We also want to foster a judgment-free environment. So share stories of those you know that have recovered. Give these people some hope. And there's no evidence that shaming has helped people to recover. Don't be afraid to initiate hard conversations. So bring up the fact that the risk of accidental death if a person turns to purchasing these medications on the street can increase their risk of dying. And educate people around you, educate your colleagues, educate your students that are rounding with you, because they are learning from us and positivity can spread. Next slide, please. Decreasing treatment stigma, treat Suboxone and methadone as you would insulin. They're both proven treatments for the disease of OUD, and try not to think of these medications as substituting one addiction for another. Also, it's important to understand that relapse does happen, and that does not mean that the person wanted to relapse. They may have just needed to use in order to prevent symptoms of physical withdrawal symptoms. It's often that need that to avoid physical withdrawal is often what leads to relapse. And the benefit of MAT treatment, medication-assisted treatment, comes from medicating the physical withdrawal symptoms, which curb the cravings and allow the patients the time and space to work on what facilitated the addiction in the first place. Next slide, please. I think it's important to take a holistic approach. And Camilla Venner, who is a PhD assistant professor at the Department of Psychology at the University of New Mexico, and is also a member of the Athabascan tribe, said we think of addiction as a brain disease. And that is a great way to reduce stigma and help people get the treatment they need. But putting the brain at the center of everything is a narrow way of thinking. We need a more holistic approach that goes beyond a person's biology. We must integrate culture, societal factors, and even spirituality, when appropriate, into mainstream medical institutions and education. Next slide, please. The National Institute of Health has a Helping to End Addiction long-term initiative, which is referred to as HEAL. The HEAL initiative goal is to speed scientific solutions to stem the national opioid public health crisis. Almost every NIH institute and center is accelerating research to address this public health emergency from all angles. It's important to look at when we're looking at how to integrate MAT with the healing traditions of American Indian and Alaska Native communities, which has proven to be beneficial and improve outcomes, that we look at the physical or biological factors, which include healthy lifestyles and behavior, encouraging those, tapping into traditions, and incorporating physical strength and conditioning. We know that can increase serotonin and the happy chemicals in our brain. The emotional and social factors, which include talking about how the person is feeling in regards to multiple things, which include security, autonomy, accomplishment, identity, and integrity. We also have the mental psychological aspect, which is the ability to set boundaries and to use teachings to problem solve. And the spiritual aspect is to believe in the natural order. So natural laws, principles, and values, and participation in cultural practices and ceremonies, or believing in a higher power, whichever that higher power may be to you. Next slide, please. Successful programs and tools. I listed the Wellbriety Training Institute, which I highly recommend that you look into. They use both Western values, which the Western values is a holistic approach for visualizing things as that all living things are equal, and that humans, though, are more important. So not necessarily equal to every other thing living on Earth, such as animals. That can also lead to a hierarchy of who's more important amongst humans. This can lead to disrespecting lives of others. The indigenous worldview is where we visualize things as a circle and that all living things are connected and contribute to the circle equally and should be acknowledged and respected as such. The Wellbriety Institute believes recovery is a process and not an event, and they have a whole program that reinforces that. They do have talking circles where they validate individual thoughts and feelings and opinions. One of the rules is that people cannot be interrupted and only one person can speak at a time. It's important for those who are taught that they could not trust, talk, or feel as they were growing up. This experience by itself has proven to be very healing. And we can also create a healing forest, which I'll get to if you'll advance to the next slide, please. So the healing forest is thought of as a dysfunctional root system that someone with OUD comes to the treatment center with. And then that root system is replaced with a better root system, which includes hope, unity, healing, and forgiveness. And the trees in the forest become healthy youth, men and women, sober leaders, traditional communities, warriors, and healthy elders. The idea is that of a forest, like a community, is only as healthy as its roots and environment. Unless individuals, families, and communities are provided with the means of overcoming this impact of the dysfunctional root system, they will find themselves participating in unhealthy behaviors again. Next slide, please. An example of incorporating a holistic approach is the Didwalek Wellness Center. And this is a Swinomish tribe in Washington that has been able to reduce overdose deaths among tribal members by 50% in 1 year. Their mission was to remove barriers to treatment in order to treat the whole person. They have an everything under one roof approach. So they have primary care, mental health, chemical dependency, and MAT treatment. Their goal is to decrease stigma, and they have found a way to ensure that everything from transportation to the front desk, all those people have a smile on their face and are warm and inviting and non-judgmental. They ensure that the bus driver is empathetic and they provide free transportation. They have said that the first person that someone may be seeing that is coming to their clinic for OUD may just be the bus driver that's dropping them off. They also have a large social work network where they meet with a case manager weekly, and they are taught life skills to help them. They remove childcare, stable housing, and transportation as obstacles. and they teach them job readiness and financial management. They also have team meetings and surveys all the time to ensure they're meeting the needs of the client. One thing that they did found is they had a 77% retention rate of their OUD patients. And of the 23% that dropped out of the 100%, everyone in the 23% had a commonality of housing insecurity. This made it hard to maintain sobriety without addressing housing insecurity. So they then built transitional housing, which they have for men, women, and families. Next slide, please. Here are some OUD documentaries and resources. The Anonymous People is a movie I referenced. The Hungry Heart is also very good. In Plain Sight is a podcast. And then this OUD, A Guide for Stigma Reduction Efforts, is from the Arizona Rethink Prescription Abuse Public Health Campaign that can be handed out to patients and is a very good resource. I talked about the NIH HEAL initiative, the Wellbriety program. I did include a YouTube video on how to conduct talking circles that came from the Wellbriety Institute. And then there is a website here with more information on the Didwallick Clinic. Next slide, please. So I would like to end with a quote from the 14th Dalai Lama that says, "Love and compassion are necessities and not luxuries. Without them, humanity cannot survive." I think if we all take that forward and use that in treating not only our OUD patients, but all of our patients, we could go a long way, or actually just even within our friendships, right? So that's all I have. Any questions for me today? Oh, sorry, you're on mute.
We don't have any questions in the chat, but I did just want to point out a couple of things that several communities, at least in Montana that I'm aware of, are really working on programs to bring MOUD, medications for opioid use disorder, within the jail systems, and are really trying to support post-incarceration.
Oh, that's great.
Super important. I know our local partnership for health center does that, and so I really encourage people to think about those kinds of programs for that vulnerable population.
Yeah, they're at a twofold higher risk than the average population. So yeah, good to hear that we're recognizing that.
Any other comments from the attendees? Okay.
My on the very last slide, my email address is on there, but it's jmiranda@mpqhf.org. There we are.
And usually we do have all of our webinars posted on our website. And so if you would like to hear something again or hear more about it, all of those references and the slide deck will be on our website no less than a week from now. So yes, and it was recorded, and the recording is also available on our website. So
perfect. Thank you all for joining.
Question from Tamara, if you have time. So yeah. MOUD also blocks, now I lost the comment, also blocks.
Yes, that's true. I see it. Yeah, also blocks the effects of opioids if used while on buprenorphine products. Yes, that's very important. Thanks for bringing that up, Tamara. Important to counsel people on and to think about.
Okay. Great. Okay, we'll let you guys go, and thank you very much for attending, and look for more from our organization in the next couple of months.
Thank you.
Okay, bye.